So we've had the privilege of having a new expert among us who is well known to many of you because she did her general surgery training here before she did her trauma critical care at the University of Washington, and also became certified in surgical palliative care, and is really a resource among us for these particular issues. But I think this is a resource for all of our departments and all of our divisions to utilize when we've got these challenges ahead. So, Dr. Curtis, Ellie.
All right, good morning, everybody. Again, I'm Ellie Curtis. There we go. Brief disclaimer, I'm part of the military, but these views are my own. Okay. So again, as they said, I did my training here at UC Davis. So yes, I am a surgeon by training. During my research year, I did something else. Does anybody know what that symbol is in the corner?
Vet school.
Vet school. So I did a master's of preventative veterinary medicine during my research year, followed by a surgical critical care and burn and trauma fellowship all together in 1 year up at Harborview University. Following that, I decided that wasn't quite enough training, so I wanted to do more. And specifically, what I found during my training here, and I can thank Dr. Greenhall for introducing to me this as an intern, was there were very few times in my training where I saw people look at a patient and say, this isn't survivable. The only thing I think I can do for you is to make you comfortable. And Dr. Greenhall showed me how to do that. I was like, this is something that I wish I did more of and I wish I was better at. And so I looked for more training in this, and what I found was palliative care. How many surgeons do you think have actually done this program? Just give me a guess. Give me a number. So 98 surgeons since 2010, when there became a test, have taken. How many think you think have passed? Not as many as you might think. So there's not many of us, but there is some interest, and as we've said, as we talk about palliative care and M&M here, there's a need for palliative care and surgeons. And so I didn't do a bunch of different palliative surgeries during my palliative care year. I figured out what it means to be a palliative care doctor from the medicine side of things. And what I think I really learned a lot from that was actually learning how to talk to our medicine colleagues to figure out what the differences are in how they work and how we work. So, has anybody heard this story? The town where everybody talks about death? It was on NPR.
Yep.
Does anybody know where it is?
Gunderson.
La Crosse, Wisconsin. And what are they famous for? And everyone has an advanced care clinic. So how did this come about? There's this guy who was a medical ethicist who ended up going to all of these terrible ICU conferences that, somebody's mom had a terrible stroke or somebody fell, terrible head bleed, or, insert other terrible thing happened to a family member. And he sat in on these conferences trying to help people decide what to do for their loved ones. And he's like, there has to be a better way to do this. And so he essentially instituted across their medical system, including clinics, including nurses as they came into the hospital, asking, hey, let's talk about possibilities for what could happen near the end of life. What things are important to you? And they were essentially all able to get advanced directives. And kind of what's interesting about this is when you can align people's goals and values with their medical care, what do you think happens to the cost of medical care? Does it go up? Sky high? No, it goes down. They spend less money on healthcare than anywhere else in the country. So when we can align people's goals and values with what they want for their end of life, we can actually save money. We can create value for our system. So today, I'm going to talk to you about the basics of palliative care. What primary palliative care is, when to get a primary care consult, logistics of palliative care, and then we're going to dive pretty deep into informed consent. So, what is palliative care? And I know most of your names, so I will call on you if nobody participates. Anyway, Dr. Kokenauer.
I think it's misnamed. It should be supportive care. Unfortunately, palliative care has a bad connotation because everybody thinks that, oh, you're calling palliative care, therefore you think the person's going to die. They're confusing it with hospice care, but it really should be supportive care.
Okay, so supportive care. So So what she said was goal-directed care for people with chronic diseases. And I think there's kind of some overlap between what Dr. Kokenauer said and what you said. So the definition I like, I modified from the WHO. Okay, I'm going to give you a second to read it. Okay. What jumps out at you from this definition? Quality, right? What else? And their families, absolutely. Psychosocial support, right? For them and their families. And again, serious illness. We are not talking about terminal illness. People do not have to be dying to need or benefit from palliative care. So, this is the old model of palliative care. So you have somebody get a diagnosis of serious illness, whether that's cancer, end-stage liver disease, kind of whatever. They do life-prolonging care, they do life-prolonging care, they do life-prolonging care, until at some point we're like, whoa, we need to stop, go to hospice. And that's it. They go to hospice and they pass away. Okay. I'm going to tell you, something that I'm sure you won't be surprised by. In the new system, it doesn't look like this. Okay? We're going to say this desk is diagnosis of serious illness. And we're going to say that desk right there is when somebody would die. Okay. By a show of hands, at diagnosis, who thinks palliative care should be involved? Okay. As I walk this way, who thinks palliative care should be involved now? How about now? How about now? Right? So a lot of you said at diagnosis, and I agree. And many of you said, as I progressed in disease, that is when palliative care should be involved. But palliative care needs to start when you decide they have a serious illness. That doesn't mean they need a palliative care consult, but that means you need to start treating the whole patient. And you need to start treating symptoms of disease, but also the patient as a person, their psychosocial needs, okay? As you can see, as the disease goes on and their symptom burdens get higher, palliative care also gets more, okay? They have hospice care, which is a bigger portion, right? Especially in cancer patients, hospice care is only the last days to weeks of life. Hospice is appropriate for people who have less than 6 months to live. And we often don't refer people until they're much closer to death than that. They're missing out on a lot of benefit, okay? And I also want to point out, there's more after death, right? You leave behind a lot of people when you die. And palliative care can help be the support for those people that you leave behind. Any questions on this? So, I want everybody to say it with me. Palliative care is not hospice.
Palliative care is not hospice.
Okay. You do not have to be dying to get palliative care. Okay? But palliative care and hospice do have some overlaps. Right? They both basically treat symptoms and they provide this emotional and spiritual support. They both do that. But in palliative care, you can still go for curative treatment. Okay? There's nothing precluding that. This can be any age or any stage of disease. Mostly it's administered in hospitals, right? We do have some clinics now, and we'll talk about that in the logistics section. And we also go to people's homes, okay? Hospice. Can somebody tell me a little bit about hospice? What do we know about it as surgeons? Carl, tell me what you know about hospice.
Mostly knew that a lot of patients and families are limited by the need to forgo curative treatment, so they feel kind of boxed out of it if they still want to try something.
Okay, that's true. If you still want to go through curative treatment, he said you can't do hospice if you want to undergo curative treatment, and that is true. Okay? And that's because hospice takes over as the person providing medications and they pay for it under Medicare and all the insurance stuff. So that's why they don't want to actually be going and like doing everything full court to prolong somebody's life, because it breaks down to a money thing. Yeah. But tell me more about what hospice is as a system. Like, where do you find hospice?
It's something that allows patients, I think, to like die at home, like that's how they want to be comfortable. And so that includes a lot of like physicians and nurses that are able to go out and give treatment to patients in their house.
Absolutely. That is what I wanted to harp on. Hospice is not a place. Hospice, 80% of people are in their own homes. Hospice is a service. It can happen in nursing homes. It can happen in your home. There are occasionally places that people can go if their symptoms are unable to be managed outside of an acute care setting. But we have hospice in our hospital, right? It can happen anywhere the patient is. And that's what I wanted to harp on. It's not a place. So they can get support at their homes, which most people want to die at their homes. So, things palliative care is not, and we hear this a lot. Palliative care is not giving up, okay? You can do palliative care along with curative treatment. You can be going as hard as you can and still want a palliative care consult. I've definitely gotten multiple consults, not necessarily here, on the palliative care side, with people asking, hey, I need you guys to make this guy DNR. We don't do that, okay? And we also don't talk people out of operations. I've definitely heard from the surgical side of things, I don't want to get a palliative care consult because I think they're going to talk them out of an operation. We don't do that, okay? What we do is goals of care. And by that, we're talking to patients about the things that are important to them and what make their life worthwhile. And if you are afraid that if we come and talk to your patient and that we're going to talk them out of an operation, then you haven't had the appropriate conversations with your patient, right? Don't be afraid of us. We're only here to help. All right, I hear this a lot too. We do our own palliative care. And I feel like people are constantly like waiting to see what I'm going to say to that. What I say to that is great. We need you guys. There are not a lot of us in palliative care, and those that there are, we're usually about 50% palliative care. There's not enough of us to do it all. We refer to palliative care not done by palliative care trained specialists as primary or basic palliative care. And every doctor, I don't care what kind of doctor you are, should be versed in doing basic palliative care on your patients. So, my observations here and elsewhere of people that say we do our own palliative care are what they mean is they do a good job of recognizing when people have their time of death called and we're just kind of figuring out what to do until then. But my question is that enough? Are they starting the conversations early enough? And my acute care surgeons, like, a lot of times we're just given the hand we're dealt. We can't do anything earlier than when they come in the hospital because we didn't know they were coming in. But my elective colleagues, you guys have an opportunity to start a lot earlier than when you see this lady coming. So, what I think we do well at the end of life is treating symptoms. Okay, those of us in the ICU, we're good at treating pain. We're pretty good at treating some of these other things, shortness of breath, edema, things that really cause people discomfort at the end. Hiccups, itching. These are all things that make people miserable at the end of life. And we're pretty good at treating the physical symptoms. What do you think we could work on? Communication. And a lot of times our patients aren't really the ones talking to us, right? It's usually their families. So dealing with kind of all of those other things that we talked about. psychological, social, cultural. How many of you know the names of all your patients' dogs? How many of you have even asked? Right? How many of your patients have you asked, hey, what brings you joy? Do you know this? How can you support these people if you don't know this? How many of you ask what religion they are? Does spirituality bring you strength? How can you support these things if you don't ask those questions? So, what does the palliative care service have that you guys don't? Time, right? I'm sure all of you are running around saying, I have an extra hour to devote to each patient. My first day of rounding here on the trauma service, I had 36 patients. I couldn't spend an hour with each patient if I wanted to. And that's the minimum amount of time it takes to do a good goals of care conversation for most patients. Okay? We have just a different scale of time, right? Surgeons are working on seconds to minutes. No, I was lucky to get to spend 5 minutes with a patient on rounds. And then rounds were taking 3 hours and I was being made fun of. Palliative care, we have time. It's a different scale. You can't judge things on seconds, not even usually minutes. It's just kind of vague shadows, right? And we're not being called away, right? How many of you can turn off your pagers for an hour and say, I'm confident enough that there will not be an emergency during this hour that I can do that? If you're sitting down trying to have conversations with people about what is important to them, how likely are they going to be to open up to you if you're constantly running out of the room to answer a page? How important does that patient seem to you? I don't know. Another thing we have is resources, right? I've got literally a team, social workers, nurses, more doctors, and expertise, right? The people here in palliative care know what the hospice services are. They know where they can go. They know what other services there are around. They have expertise in this subject. They're experts in symptom management, right? They work with people at the end of life constantly. They are good at treating shortness of breath in their liver failure patients, in their kidney failure patients, in just about everybody. They're good at this. This is what they do. And they do it for people not at the end of life, too. And they work with people to make sure that while they're treating their symptoms, it's not interfering with their curative care process. That's what they do. Okay? So when should we get a palliative care consult? So who deserves it? Dr. Mel.
Well, in our specialty, one may argue that it's a lot of palliative care. And I think the real challenge in this is that it's very, very early before they're in the hospital. As an example, I just saw a patient who had been put on hospice, severe COPD, 2 years ago, and she really should have gotten a palliative care consult because she outlived her hospice time. It took her family forever to get her off that hospice designation so that Medicare and so forth could pay for the procedure that we ultimately did on her. I saw her at a 3-month follow-up, and we really improved her quality of life. She's still not doing much, but she's much less, she's pain-free, which is what her major issue was when
Right.
she came. And I think that was an example of someone who should have had a palliative care consult way before she got the hospice role.
Absolutely. I completely agree. So palliative care, if you're even considering, talking about potentially comfort as the road you want to be on, we can definitely improve people's quality of life. Okay? Palliative service consults in the hospital. Who benefits from these? Right, everybody? Dr. Krankenhauer.
It's really important when you have patients and their families that are not on the same page, and you have to spend a lot of time talking with them, and you don't have the time to be able to sit down and spend that much time, because it may take not just an hour, it may take several hours and
Right.
several meetings.
She brings up my favorite one, complex family dynamics, right? If any of your families slightly belong on the Jerry Springer show, and like we're talking about even kids that don't get along with their step-parents who are married to their elderly parents now, right? Complex family dynamics are a great time to get palliative care involved. Cultural differences. Has anybody seen The Farewell? Can you tell me what The Farewell is about?
Well, I don't want to ruin it. The elderly grandmother in the middle has a serious illness, and the rest of the family have, well, the daughter, the protagonist on the left, has ideas about what should be done, but the family has different ideas. And the decision maker is not the patient herself, it's the family.
Right. So in some Asian cultures, they're basically like, don't tell grandma she's dying, because then grandma will just keel over and die. So they come up with these elaborate plots in order to get everybody together, but not actually tell the actual patient what's going on. How does that make you feel? Bad. Why does it make you feel bad?
Feel guilty, feel like the expectations aren't appropriately set.
We feel that the expectations set by the family are not appropriate. That makes us feel really icky. Absolutely. Absolutely.
I think the Asians have it right. And if anybody thinks that the grandmother doesn't know what the hell's going on, it's ridiculous. Of course she does.
Of course she does. And actually, she's still alive. She's still alive as of this past fall, anyway. So what Tanya was saying is, we as a culture feel it is incredibly important to like have patients have their own autonomy and have a say in what's happening to them. So when other cultures, and there are many other cultures that don't agree with this, we then feel a lot of moral distress about it. So these are patients that palliative care should be involved in. And it's not to say that the family's doing it wrong. It's to support the team and support the family through this process and making sure that the care provided to the patient is what the patient and family wants. Okay? Moral distress. We talked a little bit about that. How many of you have taken care of a very sick patient and wondered, why are we doing this? Right? This is what I mean by moral distress. Right? If you are taking care of a patient day after day, and I'll tell you a personal story. When I was at Harborview on burns, there was a 10-year-old boy that we put on ECMO about 10 days after his burn. He was on ECMO for 100 days at Harborview. He was at Seattle Children's for another 100 days. And at the end of his time at Harborview, when I still got to see him, our nurses and therapists who were working with him were like, he screams whenever we touch him. His bones were literally breaking when they were doing therapy. And my therapists and my nurses are like, I don't understand what we're doing. And so palliative care was involved. And part of that is to say, you're doing the right thing. It's like the family says any minute left with this child is a good minute. And so while we're doing stuff to maintain his life, that is a good thing. And I hear you that you're saying you don't want to do this and it's hard. But the only way we can think of to get him better is to keep doing these things and to support the teams through this moral distress. And then time. We have time. If you are finding yourself on a service where you don't have time, call us. We'll come do the goals of care. Okay? And the next couple slides are who agrees with me and things that I think are interesting. So, the American Society of Clinical Oncology agrees with me. Early in the disease course is when palliative care services should be involved, concurrent with active treatment. All right, in heart failure, palliative care services should be instituted independent of the prognosis of the patient. Okay? In liver failure, if any or all of these things are happening with the patient, please get a palliative care service consult. In kidney failure, I really like this graphic, right? Kidney failure, we get kidneys all the time. Dr. Perez takes, I feel like, 1 million of them a year. Okay? Palliative care should be involved. And the amount of palliative care can depend on how well the patient is. We are hopeful that right after transplant, people are feeling better and they don't need us anymore. But we know that grafts don't last forever. So palliative care should never not be involved. And there's also lots of social issues involved with transplant candidates that palliative care can be helpful with. Okay? This is a study from the New England Journal that showed patients receiving early palliative care had less aggressive care at the end of life, same as in La Crosse, Wisconsin, but longer survival. What do you guys think about that? Palliative care can actually mean you survive longer. All right, so logistics. At UC Davis, there's always 1 to 2 palliative care physicians on. We work Monday through Saturday. There's 2 full-time NPs. There's 1 chaplain that we share with the pediatric palliative care service. And we have home-based palliative care. So our patients that are seriously ill, oftentimes just coming to the hospital is a big deal for them. So we can actually go to their homes if they're in these areas. And this is the same in catchment area as our hospice. Okay? We also have a cancer center clinic. So any, like my surgical oncologists, wherever you are, there is a clinic 2 half days a week for palliative care. And that's already set up.
5 days a week in the cancer center for palliative care.
There you go. That's not what Dr. McMillan said. Okay, let's dive into informed consent. Who's seen this form before? All right, what do you guys have to do or make sure when you're going through this with a patient? Where are my 3s? You do this all the time. Who's an R3? Elon, what do you have to do to make sure?
Make sure the patient stickers on it.
There you go.
Make sure it says right abdomen for gallbladder surgery. Whatever the nurses want to have it on there. They do.
Say that again. Give him his.
The right patient label, right side, the wrists, the alternatives. Have capacity.
What does that mean?
It means that they understand the consequences of their actions.
Right. So they have to be able to make a decision. So he said they need to have capacity. So they need to be able to make a decision. They need to be able to kind of tell you the results of either doing the decision or not doing the decision. It has to be somewhat consistent. And it kind of has to make sense, right? So capacity. So anybody that you think has capacity to sign this form and make a decision about an operation, you should also be able to decide what is important to them. They should be able to have that conversation. So anybody that you're going to have sign this form, you better make sure you know what's important. Okay? You might recognize this guy. So he noted that surgeons that undergo about 40 hours of palliative care training, so 1 week, are less likely to recommend aggressive surgical treatments at the end of life. 40 hours of palliative care training. How many of you have had 40 hours of palliative care training by a specialist? Do you have a question? Okay, I've seen about 3 hands. Okay? So what does that mean for the rest of us? Are we recommending too aggressive care? How can you make an informed recommendation for any type of intervention without knowing what's important to people? So I have some pictures up. What do you think they mean? John,
Well, I think the pictures are representative of what would be important to certain people. Second one, I guess, is being with their spouse. Obviously, third one's about independence, and I don't know. Fourth one probably being in the comfort of their homes and more time. The first one.
So the first one, some people will say, time at any cost. I want more time on this earth. I don't care if I'm hooked up to a ventilator and machines, but time is the most important thing to me. Some people will say that. Some people will say, I want to spend quality time with my family and be able to interact and have that time with them. Some people, and this is especially true of our frail older generation, independence is fiercely important to them. And if they can't do stuff on their own anymore, that's too much, and they might not want to keep going. And then comfort. Okay? Questions that you can ask to get kind of into what's important. Where do you get your strengths? What things are you worried about? When was the last time you were able to do those things that were important to you? If you could no longer do those things, would life be still worthwhile? Can you tell me more about that? Questions like these evoke emotions. Surgeons are notorious for not being very good with those. Do not run at somebody who is crying with a box of tissues. You can have it on the table, but emotions are important. We are dealing with people in the most stressful situations of their lives. Emotions are part of that. So get used to them. Start responding to them. Even something as simple as saying, wow, this is a really stressful situation, can open doors to you. You can find out what's important to a patient. Something as simple as naming an emotion. Okay, so what if patients' goals for their recovery do not actually match what you think you can achieve? What do you do then? How can you tell someone without being like, I don't think we should do surgery? What I really like saying is, can I tell you what I'm worried about? Can I tell you what I'm worried about? I am worried that your mom is not going to come out of this no matter what I do. I am worried that they're never going to walk again. They will never get out of the nursing home. Okay? What do you think about that? Do you still want us to go through this, even though in our best case scenario, we don't think I can get you to that thing you said was most important? Do you still want to go through this? Okay. What might make a patient choose surgery when doing it, even in the best case scenario, wouldn't actually get them to their goals? Family pressure, absolutely. What else? They're scared, absolutely. Most patients don't want to die, right? That doesn't mean they want surgery, but they don't want to die. An event, absolutely. There's something they're looking forward to.
Just like doctors kind of believing sometimes that any treatment is better than no treatment, some patients probably do too.
Absolutely. So what I would call that is fear of abandonment of the medical system. People are afraid if they say, I don't want treatment, we're going to say, okay, great, see you later, and not have anything to do with them anymore. And that's just not the case. Something I like to say when I'm working with these patients that, have a possible surgery in front of them or not, is I'm here to walk this road with you, wherever it may go. Okay? That shows them that I am here with them. I don't care if they choose surgery or not. But this is me as a palliative care person. Because I do care if they choose surgery or not as a surgeon. Okay? And it's very hard for me to say this, especially as an acute care surgeon, when I have 30 other people on my list. Because if they say no, then I'm going to say, okay, medicine, take this person, and I got to run a deal with the other 35. But palliative care can say this. And hopefully those of you who do more elective long-term practices can also say this. You are here to walk this road with them wherever it may go. This is what the palliative care model should look like. It starts at diagnosis. It ramps up as you get closer to death. Hospice care is for anybody with a less than 6-month life expectancy. Don't wait until the end. They get the most benefit for the families and patients if you enroll them early. And they get support afterwards. For my acute care surgeons, we hear this a lot. I want everything done. What does that mean? Dr. Jerkovich, when somebody says this, what does this mean to you?
They don't want to feel guilty about not trying to do everything for their loved one. That's what it means to me.
They don't want to feel guilty about not doing everything for their loved one, but they're hoping for something, right? What are they hoping for? And if you can tease this out, it's really important because these require different things. Are they hoping for a miracle? Okay, if you're hoping for a miracle, I'm hoping for one too. I'm going to align myself with you. I will do what I can. I'm going to cross my fingers and hope that it works, even if I don't think it will. If your goal is a miracle, that's my goal too. And I'll tell you that I don't think it's going to happen, but I'm going to align myself with you and say, we're going to go for it. More time, and this one's harder. More time with the patient. I want more time with my wife. I want more time with my dad. And what I can tell you about that is me as a surgeon. If you're asking for more time, the only thing I can promise you is that I am taking time away from you if I take him to the operating room. I don't know if it's going to extend his life, if I can fix something. But I can tell you he is not with you while he's in the operating room. And that sometimes changes their mind about whether or not they want you to take him. Because there are lots of patients where we don't think we can help them, but we take time away from the family by taking them to the OR. Some patients and families are fixated on a diagnosis. They just want to know what's wrong with grandma, and they're fixated on it. And sometimes we can make that diagnosis by taking to the operating room. Those are people to take. A chance, even if it's a long shot and means less time with my loved one. I just want a chance. Okay. That's fine. And some people are afraid that you're going to abandon them if you say no to an operation. Which is not true. Does every healthy inguinal hernia or gallbladder or whatever need a goals of care discussion? No. They don't. So who would benefit from these preoperative goals of care discussions? And this is just my own kind of people that I think it's really important to have these conversations with before operating on them when possible. Anybody that you would expect to go to the ICU postoperatively. If you think they're going to be sick enough to need the intensive care unit, that means problems can arise which may kill them or may cause these other issues. Anybody going to the ICU postoperatively should have a preoperative goals of care discussion. For my geriatric people, where are my VA people? My VA people. You see people on the spectrum all the time. If you think that the operation you would provide or the treatment you would provide would move them from any one of these categories further down, you need to have that conversation before you operate on them. And then there's the surprise question. Who's heard about the surprise question? Dr. Romanowski, can you tell me what the surprise question is? Would you be surprised if this person dies in the next year? Would you be surprised? And it doesn't have to be from the issue that you're working on, but just in general, would you be surprised? And if that answer is no, they need a goals of care discussion because somebody thinks they might die in the next year. Right? Important. Okay, kind of big picture things. It's not a failure to ask for help from other services. We know that you're trying to see patients in clinic in 20-minute intervals. I just told you it takes an hour to do a goals of care discussion. We're here to help. You're not here alone. We are here to walk this road with you, wherever it may go. Any questions?
Ellie, that was stupendous. Stupendous. Incredibly proud of you in a million ways. I bet we have a lot of questions. It was fabulous.
Thank you.
Take it away.
Yeah, Laura.
Thank you so much for just bringing up the discussion. I think it's something as a resident I've been working on for a number of years and have still a lot of room to go. I have a specific question. I had a family that was Asian and they were Hmong, and I didn't know the right questions to get at how are we going to make the decisions or goals of care. My kind of crass was who's going to make the decision. But do you have any suggestions for questions on how to get that answer?
Yeah, I think namely doing it with an in-person interpreter helps a lot. There's also things called cultural interpreters. I don't think we have them here at UC Davis, but that can actually help word these conversations appropriately in each cultural scenario. But I would say, who makes decisions in your family? Okay, so he makes, all of the financial stuff. Is he the person I should be talking to about medical things? Should I start there and go from that? And I would ask that question with whatever family member they might not want involved. And so long as they're like, yeah, that's fine. My son can deal with that. Then I would ask the patient, is it okay if I talk to your son outside the room? And they're like, yeah, that's what's supposed to happen. Most cultural differences, they're cultural differences. They will be absolutely fine with what the family is suggesting. Now, if you have a disconnect between the family and the patient, then palliative care involvement would be super helpful for complex family dynamics. Yes. In the back.
Jenny, Geiger. How patients' goals might evolve and how... Thank you. Can you talk about how goals might evolve over time and to what degree we should adapt to that or take that into account? And as a follow-up question, another thing I think that makes us uncomfortable is when people express goals that we don't necessarily agree with or understand or think that might change. For example, if I needed an amputation, I wouldn't want to live. Those kinds of statements.
Right. So those are great questions. So we'll start with kind of the first part, which is what to do when there's evolving goals of care. And what I would say to that is this conversation is not a one-off, right? On the acute care side of things, that's kind of what we get. But these conversations need to be had on an ongoing basis, right? These conversations should start at your dinner table tonight with your family. Be present in every conversation you have with your doctor from here on out, and every conversation that you have with your patients from here on out. But it is important that every time there is a big event or just non-movement, so we have patients in the ICU for months at a time, and we should have a standard that we say every 2 weeks, we check and see what's if the important things that 2 weeks ago are still important. Okay. Dr. Gingrich.
Can you touch on how our perspective and approach to palliative care is affected by physician burnout and some suggestions you may have to mitigate that?
So as far as physician burnout, I actually don't like that term. I like the term moral injury. And do you kind of know the differences between them? I personally think burnout essentially is victim shaming, right? I'm not we're some of the most resilient, resourceful people in the world, right? But we are feeling the stresses, right? So what palliative care does, in part, is just make sure that you're taking care of yourself. So how many of you have spent an hour just working on yourself this week? No? Why not? Right? How can you do the best for your patients unless you're taking care of yourself? Same with your family. How can you do the best for your family unless you're taking care of yourself? And what palliative care would say is to help avoid this stress and the strain is figure out what you need to do in order to protect yourself from the moral injuries that you will guaranteed suffer at the hands of this job. You will suffer these injuries. So you need to figure out what works for you as far as protection. And for some people, it's meditation. For some people, it's just working with colleagues. But palliative care, when you're having those cases, are absolutely invaluable because they will come sit next to you and say, God, this really sucks, but we're doing the right thing. We need to keep going. You have somebody in the trenches with
Ellie,
you.
did you just call physician burnout physician shaming?
Victim shaming, yeah.
Which is physician shaming. I mean, that's brilliant.
Yeah.
I don't ever want to hear that term again. You're exactly right. It's physician shaming when they say we're burned out.
I'm not burned out.
You need to write that up.
There is definitely some data or some words on moral injury, but
Oh yeah, moral injury. I've seen a lot, and that is the issue. It's not, and everything else that anybody wants to call it is physician shaming. Dr. Young, I saw your hand up.
Oh, great talk. That's okay. We have a significant amount of angst internationally in the cardiac surgery community over a subset of patients, and those are the young drug addicts who are coming in for multiple valve infections. We don't know what to do about them, with them, or for them. Perfect example, we had a consult this week, 20-ish-year-old woman. She's had 2 previous tricuspid valve replacements. Comes back in with the 3rd episode of tricuspid valve endocarditis from IV therapy. So some people internationally and nationally are saying that they are refusing to operate on patients, and that the ethics committees ought to be involved. The question to you is, how does palliative care and ethics interact with this, or would you recommend they interact with this?
So palliative care and ethics often have a lot of overlap in their patients. And I think the patient population that you're bringing up, the multiple valve replacements, need both palliative care and ethics consults. Because palliative care is not going to be able to help you about, is this the right person to operate on? But it's going to help your staff deal with the fact that you are using extra resources and extra things for these patients that keep coming back. And they're going to be there to support your staff through it, but they're not going to be the ones that determine whether or not this patient is supposed to get the aortic valve. That's kind of not what they're there for. But palliative care can absolutely be helpful with those patients because it sucks to have these patients that keep coming back day after day, week after week with abscesses, things on their valves, and having to take care of them. But that doesn't make, the problem's not going to go away.
Dr. Cantor, who probably also doesn't need a microphone.
So, great talk. Don't get me wrong, great talk. And something I believe strongly in.
Yes.
But I would challenge you a little bit because, one of the most telling slides is the TEML study that you showed. And for those of you who didn't pick up on that, the TEML study is the New England Journal randomized trial. That was published in 2010.
It was.
So that's 10 years ago. And, I would argue that not much has really changed. And I would argue that we've heard this talk before. Dr. Bridget Fahey, who is a former resident here, who's also been a champion of palliative care, gave a very similar talk 5-7 years ago as part of her traveling fellowship. So what is needed to really make more substantive change, to really implement these complex ethical, family dynamic communication issues that, how do you really think to move the needle more than, everyone's going to walk out of here and be like, great, we love palliative care, but, week, 2 weeks, we're going to have another one of these disaster cases that are presented where, nobody really had the message sink in potentially.
So what I would say to that is you have to consult palliative care for them to be helpful. And we don't. So the palliative care consults here, 80% are medical based, right? Only 20% of their patients come from surgical services. And maybe your service is one of the people that consult us. But as a rule, we as surgeons do not, and we need to do more. So we can only be helpful if you consult us. Dr. Salcedo.
Oh, thank you. Great talk, Ellie. Welcome back. I was wondering what you feel like about the idea of, like, in the interest of the notion of nudges, that if we were to institute a policy or work on a system where every ICU admission for a surgical service included a palliative care consult, and it was the responsibility of the ICU service to actively decline the consult in order to have palliative care not participate in the care of a patient who's admitted to the ICU.
I think that is a great first step. I think that there are a lot of issues that would come up with that, especially because, especially on the trauma service with the high turnover, people might only be in the ICU for a day or 2 days before they get kicked back out from the floor, or kicked back out to the floor. I think those patients that are in the ICU for longer than 72 hours should be having a palliative care service consult, like across the board.
Dr. Irwin, let's hear from a plastic surgeon. What do you need palliative care?
Yeah, great. So I do occasionally help with cancer reconstruction, okay? I haven't called you for a hand patient yet. Similar thought, and I thought Skeeter might sort of touch on this idea, but I do get prompted by Epic, and I don't want to bring up the EMR, but I'll put in a case request, and it'll say, do you want to order a glucose and an EKG on this patient? So this would be an iterative process, and it would probably be the bane of everyone's existence. But this is just like to float a thought out there. Is there a way to try and come up with an algorithm? It's so hard. Obviously, this room full of intelligent people can't identify the patients that they should be having, really targeted discussions on. Mm-hmm. Although everyone obviously should have goals of care. But as an institution, maybe a 5-year-long trajectory, a project for, you put in the case request, because we're all surgeons here, and it says, hey, this person has aortic stenosis, age over whatever, and then you have to sort of opt out, that whole sort of opt-out idea.
That's a great idea.
So many. Yeah, Dr. Cole, then we'll go to Dr. Romanowski, and then one last question I have a lot of here.
Okay.
So I'll answer some of the questions because I've been involved in the administration of palliative care for at least 5 years here, working with Jack McMillan, Nathan Paramedic, Annie Cardigan, Luke Iglowitz, and it's a very resource-constrained service. I think you'll recognize, and if you saw that little line, unfortunately right now they're a Monday to Friday, 8 to 5 service. They are constrained. They're getting into more hours as they recruit people, but the pilots that we've worked on in terms of the opting out functionality is right now admission to the bone marrow transplant unit, admission to pulmonary critical care unit in which palliative care is automatically consulted. And right now in the cancer center, anybody with advanced stage lung, GI, ovarian, or breast cancer has a mandatory palliative care consultation at the time of diagnosis. So we're slowly moving the needle into earlier consultation in both the in and outpatient setting.
And I think that's a great start, and there's obviously room to go. And I think you're not going to get more resources unless there are more consults. And you can say our line is farther. So I think we should all.
Dr. McMillan said consult them. They want to be overwhelmed.
I will say what I was going to say is similar to Dr. Bowles because I had made a personal decision that I was going to consult palliative care for every burn patient over 20% who was over the age of 60. And when I called them for my first one, they're like, what do you want us for? We don't really have time for this. So I think we should work with our palliative care team and Ellie to figure out what they can handle and a system. We shouldn't just all start, every ICU patient gets a consult because, as I said, I tried to start this on my own and was met with a little bit of, you're calling me for what?
If you ever find that on the palliative care service, like as a general rule, palliative care should just take all consults as far as I'm concerned. If we're having trouble figuring out your question, that's our problem, not yours. So if you're finding that to be an issue, please email me and we will address it.